Now the session is open for any comments and questions from the audience or my co-chairpersons. If there is no comments or questions, I just want to just add one important thing, that you have already highlighted very important aspects, as there's nothing more to add on that. But the importance of risk scoring system for non-ST elevation MIs to risk stratify between the high risk category and intermediate or low risk category. Importance of troponins, because many times many physician colleagues of us, they won't do troponins in a temporal order, and doing only one troponin may not be important, as you have rightly pointed out. Importance of the invasive strategy, particularly if the facility exists and it can be done within less than 120 minutes, that's ideal for it. But many times we don't have a facility existing, or the patients are delayed a lot. In those circumstances, a city like ours, the many time, pharmaco-invasive strategy still holds quite a good approach. So thank you, Dr. Pravesh, for your wonderful deliberation. Now,
thank you so much, sir. Thank you.
we should invite the next speaker. I will ask my co-chairpersons to invite Dr. Akhil, I think. Dr. Akhil is the next presenter. No? Hello?
Okay. Okay, so we will move ahead. Our next presenter will be Dr. Akhil. He is a professor in Department of Cardiology from KGMC. Dr. Akhil will talk on ESC update on cardiomyopathy. Now, welcome, Dr. Akhil.
Am I audible?
Yeah, you are audible, Dr. Akhil.
So, I think my slide also visible to all of you?
No, not yet.
No, not yet.
One second.
I think you reshare the screen.
Yeah, but don't think I could not able to
Initially we have seen your slide once, then it is gone back. So if you reshare, probably it may reappear.
I think you open your PowerPoint once again and reshare it. Share
Yes.
it again.
Thank you.
No, you will have to once close the presentation, I hope, and then open it and share the screen after that.
Yeah. I think now is visible.
It was, yes, now it is visible.
Yeah, make it a
Yeah.
power.
Sorry for this technical glitch, and first of all, thank you very much to HIC to give me the opportunity, and good evening to all of the chairpersons and my dear colleagues. Today, my topic is just to give the overview about the 2023 ESC guideline and the management of the cardiomyopathies. As already my chairperson already mentioned, that it's difficult to summarize the guidelines in 20 minutes, and these are the first guidelines. These are not update. First given by the any international society, the guideline about the cardiomyopathy management. So just bear with me. So as I just start from the introduction, as you all know, the cardiomyopathy defined as the myocardial disorder in which the heart muscle is structurally or functionally abnormal without presence of the any significant other explanation. And ESC guideline, ESC society giving these guidelines to help the healthcare professional with the evidence-based management. And now the ESC or the cardiovascular society trying that the most of the cardiologists or physicians should manage these patients. These patients should not be reserved to management to the specific cardiomyopathy centers. So now the approach is changing that most of physicians should treat these patients. As we all are aware that the very few, even though the cardiomyopathy is not common, not uncommon, but we have very few randomized trials in at that present time. So most of the guidelines recommended on the behalf of observational cohort studies or expert consensus opinion, and all the recommendations are new in these guidelines. So this is the first attempt by any international cardiovascular society to give the management guideline for cardiomyopathy except the SCM. These guidelines have some unique characteristics that they start identifying the patient on their phenotypic presentation. They categorize the patient according to the phenotype. Then they give the importance for the ventricular myocardial scarring on CMR, and give this scar importance in the management as well as the prognostication. There are some patient-specific pathway to identify the patient before presentation, at a time of presentation to advanced management, and multi-parametric approach is recommended all over the presentation. Updated recommendation for clinical and genetical cascade screening is included. Almost the focus should be given from the start management on the pediatric age to transition to adult age up to the end of life. Sudden cardiac death risk stratification updates should be included. Genotype in assessment of sudden death risk also updated in these guidelines. Left ventricular outflow obstruction tract obstruction management also updated, and multidisciplinary approach is again recommended as in almost all cardiovascular diseases. So I will discuss this presentation in the four part of the my presentation. First is the diagnostic approach, second is the risk stratification, third is the specific management, and finally the newer updates. So, as we all are aware, the most important aspect of the cardiomyopathy is that identification of patient and correct diagnosis. Patient can be presented to us with some vague symptoms like the dyspnea, palpitation, syncope. They may be identified accidentally during the routine investigation, or there may be a family history. So, the patient presented to us for the screening. When these kind of the suspected cardiomyopathy patient presented to us, we have to identify their morphological and functional characteristics by the different imaging like the echocardiography, ventricular morphology, or ventricular scarring by the help of the CMR. Some additional trait like the arrhythmic presentation or conduction disorder, sometimes pedigree analysis of patient, genetic testing of patient, extracardiac manifestation are the important part of the some cardiomyopathy. Some laboratory tests and pathological findings may help to identify our phenotypic diagnosis to exact etiological diagnosis. So our motive is to diagnose patient as a broad category according to phenotype, but we have to provide the exact specific etiological treatment by the diagnosis, made diagnosis by the specific etiology of the patient. So according to the phenotype, we can divide the patient in the five broad categories, which one is the most commonly the hypertrophic cardiomyopathy, then dilated cardiomyopathy. Third one is the new nomenclature, not the new modality. This is the non-dilated LV cardiomyopathies. Fourth is the arrhythmogenic right ventricular cardiomyopathy, and fifth is the restricted cardiomyopathy. We can identify these all patients on the echocardiographic imaging as well as the CMR. After making the phenotypic diagnosis, we have to provide the general management of all these patients, which is the management of the heart failure as well as the risk identification of SCD, implantation of ICD, and some of the phenotypes require some specific management like the SCM require the LVOT obstruction treatment. So we can treat the patient accordingly, specifically according to their phenotypic characterization. So when we come to the our management of these different morphology which can be made on the imaging, like the ventricular morphologic trait like the ventricular hypertrophy of the left or right, ventricular dilation, non-ischemic ventricular scar, or function trait like systolic ventricular dysfunction or ventricular diastolic dysfunction, which may be regional or the restrictive physiology. So, as I earlier discussed, symptomatic patient presented to us, we go through the very cheap or very easy investigation like the ECG, family history of the patient, the pedigree formation, and then we suspect the specific kind of the cardiomyopathies. After that, we go for the morphological or functional assessment by the imaging, and we can identify and decide our patient in which category of the phenotypic presentation is there, then SCM, DCM, ARVC, RCM, or NDLVC. After making the phenotypic diagnosis, now we should have all attempt to make the specific etiological diagnosis by the help of the pedigree analysis, genetical testing, extracardiac manifestation, laboratory manifestation, or the pathological investigation, and then we want to reach the specific etiological diagnosis, so we can give the specific treatment to our patient. Again, like the other cardiovascular disease, multidisciplinary care is the class 1 recommendation in all patients with cardiomyopathies, and it should be provided to the pediatric patient up to the transition in the adolescent. Patient pathway, as I earlier mentioned, that the cardiomyopathy phenotype should be the first step of the diagnosis. It's only the beginning, not the end of the diagnosis of patient. So first step is the phenotypic diagnosis, then when we can go for the specific diagnosis by the genetical or the imaging identification, and multi-parametric investigation should be a ideal choice for these kind of the patient. And these investigation can lead to the specific diagnosis which has the specific genetic manifestation, which has the specific treatment as well as the specific prognostic implications. So we have to consider all these kind of the things. Sometimes some red flag sign is always is presented. We should always note them and try to inculcate in our diagnostic diagnostic performance. So pedigree, the inheritance of the disorder, family history can give ideas what the inheritance of this disorder, autosomal dominant, recessive, or X-linked. Sometimes extracardiac symptoms like the deafness, muscle weakness, paresthesia can give us some ideas. Physical examination, muscle weakness, ECG has some specific criteria, some laboratory or echo finding give some morphological criteria. And these are the different aspects of the diagnosis. I want to focus that the very easy or cheap investigation like the ECG has the significance as much as the endomyocardial biopsy. So any of the steps starting from the history to endomyocardial biopsy has their own significance. So we should give the specific attention to each and every, starting from history to the endomyocardial biopsy. Then we come to the recommendation of the different diagnostic workup. So every patient who has the suspected cardiomyopathy or established cardiomyopathy should go the clinical evaluation, pedigree analysis, ECG, Holter monitoring, laboratory test, and multimodality imaging. Recommended as the class 1 recommendation level C. And genetical analysis or their family history, family tree should be made. It's also recommended as the class 1 level C recommendation. Different extracardiac manifestation, different specific presentation may give us idea of what the our phenotypic diagnosis is going through, like the learning difficulty, sensorineural deafness, myotonia, paresthesia, carpal tunnel syndrome. We all are aware that these findings can give us idea for the specific diagnosis. Sometimes muscle weakness, ptosis, lentitions, some skin manifestation also have specific characterization for the some diagnosis, and we can easily identify the diagnosis with help of the skin lesions. Now come to the ECG. ECG again has some criteria, some additional features which give us to some extent of the idea that which SCM phenotype we are going to address or going to deal. So as in SCM patient, sometimes short PR or pre-excitation is give some specific idea, AV block, extreme LVS. So these are the features which can suggest the specific diagnosis. They are not, although they are not confirmatory diagnostic parameters similar for the DCM or specific diagnosis. as you can see that the cardiac amyloid or Anderson-Fabry disease both look like the similar on the echocardiographic imaging, but by the echocardiography or the pathological finding, we can ECG or pathological finding, we can easily identify the kind of the condition. These are the some first investigation, first level of investigation, which should be considered each and every patient of suspected cardiomyopathy. Class 1 indication for the first line of the investigation, and class 2 second level investigation should be considering specific considered diagnosis in specific population, which recommended the class 2 indication. Echo should be done for each and every patient of the suspected cardiomyopathy, and it could be used at every stage of the management, from starting from the diagnosis to the prognostication and management. These are the some morphological features how we can identify the different kind of the cardiomyopathy as by the echocardiography. Let's come to the CMR, which is focused investigation, or I can say the updated investigation for the cardiomyopathy management in 2022 ESC guideline. It's recommended every patient as an initial evaluation of the cardiomyopathies. It also included as the class 2 indication for the risk stratification and management. It also recommended as the class 2 indication for the management follow-up, and it also included in the genotype positive patient who didn't have any phenotypic manifestation as a class 2 indication. Some other investigation like the CT or the nuclear imaging also indicated, like the in patient of the cardiac amyloidosis, bone tracer scintigraphy investigation is recommended at the class 1 level B investigation. Sometime when the echocardiographic imaging not good, CMR is contraindicated, cardiac CT can be done as the class 2 indication. CT also used for the coronary artery assessment, or FDG PET for the sarcoidosis patient. Now I come to the genetic testing and counseling. We have to answer these 4 questions for every patient of the cardiomyopathy. How we can do what is the genetic basis of this cardiomyopathy, why we need to genetic testing, and who should have genetic testing, and how the genetic testing should be performed. I try to answer all these questions, as we all are aware that any disease which has the large effect has the very rare incidence in our population, but the disease which have the very low impact on the pathophysiology, these have very common presentation. So this is the Mendelian law of how we can have the presentation in our population. And the presentation of the different genetic disease may be monogenic, near or monogenic, oligogenic or polygenic. It depends on the manifestation when the disease crosses the threshold of the disease manifestation. These are the different kind of the pedigree, how the patient can present it, and how we can identify the specific inheritance of the cardiomyopathies. Why we need to genetic testing? We need the genetic testing for the patient, for their relatives, and sometimes for the disease, to identify their specific genetic abnormality to help their survive relatives. So for patient, it may help for the diagnosis, for prognosis, therapy, or reproductive advice. For relative, accurate assessment of the family risk, predictive testing, or molecular autopsy. This is the wall diagram chart. You can see how we can perform the genetic testing. It should be class 1 indication for any patient who already have the variant present, and in patient who did not have any kind of the variant present, and we are suspecting according to the cascade clinical screening, it again recommended the class 1 indication. Genetic study also had some prognostic implication. You can identify the different kind of the genes for the specific prognostic implication of the different type of the cardiomyopathies. So these are should be in your knowledge to identify the risk of patient. Some benefits of the genetic testing, as we all are aware that the CRISPR providing the treatment to fix some genetic disorder, which is again a method of treating the genetic disorder, and we are hopeful that in future we have the therapies commonly in our practice. So genetic testing as well as the counseling recommended all the patient of the class as the diagnosed as the cardiomyopathies. So again, I will come to the generic counseling. Again, recommended all the patient as well as their relatives and multidisciplinary team should be included to give the counseling in these patients. New concept in the sudden cardiac death risk assessment in cardiomyopathy patient, as we all are aware of, almost maximum mode of the death in these patients is usually sudden cardiac death. So we have to identify their risk profile and we have to manage accordingly. And these guidelines given us idea that the risk score is the better way in comparison to risk factor assessment. So, as we all are aware that in early age sudden death is much more frequent in comparison to older age. So, we have to include these patients as beginning when we diagnose and give to their shared decision approach. The physician as well as patient should include in the conversation all factors like the current evidences, comparative cause of the death, burden of the alternative risk, simultaneously cultural factor, social factor, religious belief should be, or economic factors should be included before the making decision. Implantation of how we can recommend these ICD implantation in the patient. So any patient who had the good quality of survival more than 1 year should go for the ICD implantation if they require for it. And again, the ICD implantation should be evidence-based, should be decided by the information and shared decision benefit. Every time, whenever you discuss the patient about the ICD, you always discuss the benefit, harm, and possible consequences of this therapy. So how we can identify risk factor assessment, which is the always is followed by the almost every cardiologist. High risk group go for the ICD recommendation, low risk reassure and reassessment. Now the newer concept is the risk assessment, not the risk factor assessment. Go for the individualized person, their risk assessment for the individualized patient, and then take the individual decision according to the patient education, their understanding, their economics, or their social or religious factors. So, as I earlier mentioned that the SCD risk stratification should be done at the time of the diagnosis, and if patients are not indicated for the ICD, then every 1 to 2 years you should reassess the patient. The use of validated SCD algorithm or score should be added in the shared decision making, and which is recommended. Ideal risk prediction, as we all are aware, there is no SCD or SCD, there is no window between. So when patient has the minimum risk, again the risk of the SCD started well before when the end of this phenomena happened. So any patient who requires the SCD, we have to identify the kind of the patient. As this is the bar diagram for the SCM patient, you can identify different risk factors like the ACE, unexplained syncope, LV outcome gradient, maximum wall thickness.
Dr. Akhil, please summarize.
Yes. So these are the different categories how we can identify it and give the treatment, and lastly is the how we can give the therapeutic options. So the management, general management of the all cardiomyopathies is similar to their heart failure profile according to the reduced ejection fraction or the preserved ejection fraction. Some specific treatment may require for the phenotypic type according to the phenotypic type. As the LVOT gradient management in the SCM, which and sometimes the comorbidity like the atrial fibrillation may be required treatment, and in the case of the atrial fibrillation, ablation is always recommended. The class 1 indication in patient who cannot, who already on the one class of the antiarrhythmic drug, and 2A recommendation in the patient who did not want to the medical treatment. The rate control is not considered as the superior in comparison to catheter ablation. So all cardiomyopathy patients should be given the catheter ablation choice. And the anticoagulation, when we come to the anticoagulation patient of the SCM or the RCM, every patient should be anticoagulated without the Chadwick score, considering the Chadwick score. Other patient, other DCM, MDLVC or ARVC patient can be considered according to the Chadwick score, standard Chadwick score course profile. Heart failure management, I already mentioned that the standard heart failure management should be given this patient with consideration that the RCM patient beta blocker should be avoided. In SCM patient or RCM patient or cardiac amyloidosis, diuretic dose should be considered very cautiously. Over diuresis can be fatal. Again, this is the important aspect. You should treat the particular case, consider the patient, not the heart. So whenever you have a patient who had the deteriorated biomarker or symptom, they should be referred to the cardiac transplant, not always follow the LVEF of the patient, because sometimes you may be late when the patient has the poor LVEF. How we can manage the left ventricular outflow? All are aware. We develop a class 1 verapamil, then the disopramide, mavacamten can be indicated as the class 2 A indication. Sports recommendation. This is the important aspect in these guidelines. They obsolete the recommendation that any patient of the cardiomyopathy with sudden death should not have the exercise or the competitive sports. They identify a specific variant of the disease where this is contraindicated. So all patients of cardiomyopathy should have regular low or moderate intensity of exercise. High intensity exercise is not recommended in the obstructive SCM high risk cases, ARVC cases. Rest of the case patient can have the moderate to high risk of the sports activity. So in summary, please try to identify your phenotypic diagnosis. This is, please remember that this is the beginning of your management. Go for the specific etiological diagnosis. Try to involve patient as well as they are related to in the management. Shared decision is the key, and refer the patient as soon as possible for the heart transplant if the medical management is not going to help. Thank you very much.
Thank you, Dr. Akhil, for your elaborative presentation. Now house is open for any question.
I just had a small comment. Thank you, Dr. Akhil, for your nice covering of the total cardiomyopathy topic. I just want to spread this message among all of our colleagues, because most of us are doing echocardiography for in the day-to-day clinical practice of ours. As Dr. Akhil has already mentioned that the phenotypic diagnosis of hypertrophic cardiomyopathy and dilated cardiomyopathy and all these were when established. It is always important to establish the etiological cause, because I still remember a patient who was presented to us as a infiltrative heart disease, pericardial effusion, and diagnosed as the etiology was not investigated. Later on, when he was detailed investigated, he was found to have a multiple myeloma and a cardiac amyloidosis. His multiple myeloma was treated, and over the time course his LV function has improved, as cardiac amyloidosis part has improved, and 10 years down the line we are following him, still he is quite well. So it is always essential to establish the etiological diagnosis as well. Many of the patients, they do have a carcinoid syndrome presenting as a hidden oncological diseases of the renal cell or other ovarian cell carcinomas. So etiological diagnosis also has to be taken care of, and we need to investigate them. Now cardiac MRI, endomyocardial biopsy, these are high investigative tools are available with us, though we don't have all the time access to them. But these all can be done at advanced centers where people are working specifically for heart failure clinics and all.
So thank you our chairperson for chairing the session. Now I request Dr. Soumik Ghosh to give memento to Dr. Ajay Pandey sir as a token of respect. ऑनलाइन वालों को ऑनलाइन दिया जाएगा
और क्या, जब ऑनलाइन है तो ऑनलाइन ही लेंगे,
ऑनलाइन दिया जाएगा बिल्कुल. Once again, I request Dr. Soumik Ghosh to give memento to Professor Deepak Gautam. फोटो खींचो. Now I request Dr. Krishnaji Pandey to give memento to Dr. Nilesh as a token of respect. Odd man out. No. You are not odd man out. Now I request Dr. Harshit Jain to give memento to Dr. Balaji. Now coming to the last session, I am inviting the chairperson for the last sessions,